You talked about Greylands and people with intellectual disabilities then, and then now you are the executive at Enable WA. You also have currently clients who have intellectual disabilities.
Many.
So if you want to paint a picture for the listeners and people who are watching us, what's the difference in terms of the care we provide? What's the model of healthcare or model of services? What's the difference between 40 years ago, what you have seen, and so that people get the perspective of the difference then and now?
Yeah, and it's a huge, major change. So up until about the mid-80s, things started to change in Western Australia, where people with an intellectual disability or have autism disorder or a whole range of issues, acquired brain injury, say, who were institutionalised in a psychiatric hospital like Greylands, there was a move to deinstitutionalise and to move people into different sort of spaces, including group homes and those type of things. It took time, and it took a long time for that to happen, but it was a good way of being able to sort of move people to a better space and a better place, and have people around them who were trained to sort of help them and support them.
Was that transition? Sorry to interrupt. The transition was clinical based, or was it based off because of community was thinking differently? That the community and the society had higher expectations of the state government or the Commonwealth during that period, or it was more clinical driven?
I think it was more clinically driven because psychiatry was actually being able to role delineate and see that the job in mental health in those days was to treat people with serious mental illness, such as schizophrenia or major depression or bipolar illness. People who had an intellectual disability needed to be treated and cared for and supported in a different way. Acute psychiatric treatment is very different from treating someone with an enduring disability. And I think that was it was driven by families, it was driven by a change in thinking, really. And WA was just following what was happening in other states and other places. But at the same time, it was a good thing because it actually made the system or the people or the community or whoever focus more on what people with an intellectual disability could do. Or, I mean, the first person I met with an autism disorder was very, very unwell. You know, they were basically medicated or banging the head against the wall. It was pretty, and we would be having to try to stop them from doing that. Nowadays, people are assessed earlier. They're picked up quicker. There's a much better community awareness. People advocate and lobby. There's lots of information available. You've got a much more informed consumer, which is fantastic, because informed consumers keep people like me on their toes. And that's why you need consumers involved, participants or families or carers, whatever word you want to use, involved at policy level, involved in decision making. You should have a consumer advisory group or a client advisory group. You should have a group that's providing you about what the local community wants when you're developing policy. And so for people with an intellectual disability, what you saw over time was a real shift away from that institutionalised medical model to a much more for-purpose model, which was based on finding the level of support that they needed to live their best life, which is one of the core values of what Enable does. That's one of our core principles, that we are working really hard to help to support people to live their best life of their choice. Which is very different from what I was trained to do as a mental health nurse in the 1980s.